Dr. Kenneth Bruscia.
Thank you all. I want to start by thanking AMTA. AMTA has supported and recognized my work all along, and I'm very grateful. Thanks to Ronna Kaplan for inviting me. Thanks to Andy Farbin for being a friend for so long. So thank all of you also for giving me this opportunity to speak on behalf of Sears. I'm dedicating this speech actually to Sears because Sears was really a master thinker, first slide, master thinker in music therapy. One of the things that you immediately can recognize in any of Sears's writings is that he was constantly looking for ways of thinking in music therapy. He was really at a disadvantage. He was doing this 60 years ago when practice was just beginning. So he was busy trying to really imagine the different avenues and the different ways of thinking that music therapists could use to enrich and expand their practice. So I'm coming to you today sort of, the easy way. There's 60 years of practice behind us. And so what I've tried to do is to look at those ways of practice and to think like Sears and say, well, what are the different ways of thinking that we have evolved? And is there a way of presenting that to you which will help you to enrich your own practice? Here's another slide of Sears. He was a baton twirler. Can you see the baton? So he had different ways of thinking too. And okay, next slide. What I've done is I've identified 3 ways of thinking in music therapy. And this comes from those of you who
we need to hear you a little better.
Okay. Part of this thinking comes from the chapter in my... Part of it comes from the chapter in my book, Defining Music Therapy, the chapter on dynamics. And so this has been a real reworking of that chapter because as I go back to it 13 years later, I say, oh, this isn't quite what I want to say. So here's what I come up with. I've come up with 3 ways of thinking. Outcome-oriented thinking, experience-oriented thinking, and context-oriented thinking. In the outcome-oriented thinking, what you're trying to do as the therapist is you're trying to really induce a very specific, predictable response in the client. I don't want to say that the response is an external response or an internal response or a musical response or a non-musical response. It's a response. And your job is to somehow get the client to have that possibility. Experience-oriented is not quite as predictable. What you're looking for is that you're looking for a likely response, but you're looking for an arena of responses. And so what you do is that you give the client some kind of an experience that helps them to identify the therapeutic alternatives that they have, and then for them to act upon those alternatives that they think are preferable. And then the final, the context-oriented, is something which is developing now in Europe especially, but also in this country. And that is the realization that if you work with a client, sometimes it's not enough to just work with a client, but that it's all the other layers, the social layers, the cultural layers, the environmental layers that surround and influence that client. And that those layers have to be changed. Those contexts have to be changed or addressed as much as the individual themselves. Okay, next slide. So here's outcome-oriented thinking. Is that big enough for you to read? Okay. So there are 3 basic strategies that I've identified. One is to use music as a stimulus or a reinforcer to induce a very specific response. Now, obviously the response is going to be operationally defined as therapeutic. Okay, so very predictable, very specific. Second way is to use music therapy sessions to affect measurable non-musical changes. This is your traditional kind of clinical trial where you're working with a variety of methods in music therapy or even with a specific method of music therapy, and you're trying to, let's say, use improvisation to decrease depression, and you're going to measure depression on some kind of scale. So that's the clinical trial. That's another strategy that's under this outcome-oriented thinking. The next one is to engage the client in some kind of music activity that requires a specific musical response. For instance, you use instrument playing to help a client develop some kind of motor skill, or you use singing to increase breath control. You use rhythm imitation to increase short-term memory. So there's a musical response, and that musical response definitely has some therapeutic implications that you can point to, identify, and define operationally in terms of measurements. Next slide. Okay, the characteristics of the outcome-oriented is that the basis for practice is empirical evidence of cause-effect relationships between the music and the target response. You also rely upon previous clinical evidence. You also rely upon theory. But the outcomes are predetermined, specific changes. That's the important thing about this. Treatment is problem-oriented. By that I mean, and you'll see more what significance this has. Treatment is problem-oriented in that you clearly have an idea of what the client really needs. And the client may or may not be aware of that need, but you are really trying to solve a problem. And so you're trying to find a response that solves that problem. Okay, so efficacy depends upon predictability and control of variables. The main orientations are medical, behavioral, educational, cognitive behavioral, and this is an idea of music therapy as a science. We know it is. Now, just imagine for a minute that there are roles. Next slide. You see that the therapist here is an expert on research, on evidence, on cause-effect relationships, on the properties of music and how those properties of music can be used therapeutically. Music is used as a tool. It's a means to an end. It's that old definition of music therapy. Music therapy is the use of music to achieve non-musical goals. It's using music as a means. The client is like a consumer or recipient. Depending upon what kinds of problems the client has, they may or may not be involved in the treatment decision. Okay, next slide. Experience-oriented. First strategy is that you engage a client in a music experience, and that music experience provides an opportunity for that client to, first of all, almost confront or realize the therapeutic issue. And then within that experience, you take them through so that they can identify the alternatives that they have within that experience. So for instance, let's say if we start an improvisation with a group of adolescents and you don't exactly know where it's going. You know, you have a general idea. You want these kids to cooperate. You want them to function as a group. You don't exactly know what kind of role each of them are going to take. So you start the improvisation, and then from within that, you see how they're responding, and you see how they may need to respond in different ways. And so you try to guide them into finding a way of responding that's different. That's their choice, not necessarily your choice. So that's one way. You engage a client in an experience. And it's a process, in other words. Like improvisation is a process. Guided imagery and music is a process. The second way is that you assist the client in creating a musical product. You help them to write a song. You help them to record an improvisation. You help them to make any kind of musical product that somehow represents who they are or represents the kind of therapeutic progress that they've made. probably the best example of this are songs at the end of life that individuals will write not only to provide a self-portrait of themselves to themselves, but also to their loved ones, or also to even just give a message to a loved one. Concerts given by children with developmental disabilities. There's a product-oriented, and it's in that producing a product that the child finds his way or her way of overcoming their challenges. Okay, next slide. So the characteristics of this are that the basis for practice are interactions with the client. It's like you're glued to what's happening in the moment. And you also rely upon the experience in using that process or using that experience with other clients. And then you also rely upon clinical models, theory, and research. So for instance, the good examples of these kinds of thinking are the Nordhoff-Robbins music therapy, guided imagery in music, and analytical music therapy. So the therapeutic alternatives then emerge from the engagement in the musical process or product. The efficacy depends upon the relevance of the music experience to the client and the therapeutic issue. And here you've got another shift. The evidence of change can be subjective or objective. Not everything that happens in an improvisation can be measured. I mean, we can say that we're measuring, but whether it measures anything that's really relevant is the question. And so, although you can say, well, we can measure the times that the client interacts properly or interacts in an efficient way, I'm not sure exactly in that context what that means. That doesn't mean it's not an important measure. It's just that in this context, you have to be able to see what the client says is important. Because if the client turns around and says, I don't like this, then you've got a good measure of how he changed his response, but you have a poor measure of whether you've really changed his experience or not. So the orientations here are psychodynamic, humanistic, and Gestalt. And in this frame, music is more of an art. Next slide. Comes context-oriented. The whole thing about context-oriented, and some of you already know about trends in community therapy and trends in trying to get music therapists that are really more involved in all kinds of other kinds of external change to the client. What you have to do this is you've got to situate yourself. And situate yourself means to be reflexive. And to be reflexive means I have to think about who I am and what I do in relationship to my own background and to my own culture and to my own circumstances. And if I work with you, I have to be reflexive about where you're coming from and all the influences that are on you. And so that somehow I've got to negotiate those contexts before I even begin to know what's needed from a therapeutic point of view. Sometimes what's needed is that you need to change. Sometimes what's needed is that you've got to operate on your environment, and your environment has to change. I'll give you a good example. I mean, here's where feminist theory comes in beautifully. You're working with a woman who's been abused. Well, sometimes the whole resolution of that abuse is not just making her feel okay or empowering her and making her feel strong, but it may also mean that she's got to confront her environment and she's got to do whatever she can to change attitudes towards oppression of women, and that is part of what she needs to do as her way of becoming, having a better quality of life and have a better sense of well-being. So in this way of thinking, what you then do is that these are based on Brynjolf-Stiga, you find out what setting is best suited for your work. For instance, he worked with some mentally retarded, what he called mentally challenged adolescents, I should say. And as soon as he started working with them, they started saying, oh, well, we want to play like this band in the community. And as soon as they said that, he began to think, well, maybe eventually we're going to have this group perform outside just the way that band performed outside. And then eventually that grew into they wanted to be a part of the band. And if they wanted to be a part of the band, he had to negotiate by teaching them the skills, giving them the skills that they need to participate in that band. But then he also had to work with the band to be able to accept and incorporate those kids into the band. That's the essence of a contextual approach. The need in some ways emerges as the client begins to indicate what it is that really will resolve the problem. Okay, characteristics of this. The basis for practice are all these contextualizations, how the client, therapist, music, and health are contextualized. The outcomes are both preset or emergent. And one of the things that I'm beginning to understand now is that in this way of thinking, you can use either outcome thinking or experience thinking. You can look for changes that are measurable and predictable. You can look for responses that are predictable. You can try to elicit and induce specific responses, or you can also provide experiences which allow the client to find therapeutic alternative that best suits them. So here then, the question really becomes whether the change is going to take place in the client or the environment or both. Here, therapy is more likely to be resource-oriented. You're constantly trying to find the resources of the client and the resources of the environment that can be applied towards the betterment of the client. And it's not problem-oriented because you're not, in this way of thinking, for instance, you don't even classify client populations. You don't even pathologize. It's more aligned with positive psychology, thank you, positive psychology and feminist theory and a number of other theoretical streams. Efficacy depends upon the reflexivity of the therapist. In other words, this is really unusual because for the first time, the competence that you have to have is not your knowledge, it's not your knowledge of research or your knowledge of music or your ability to engage people in music experiences. It's your ability to look at yourself and to look at the client in relational contexts. In some ways, it's really a spin-off of countertransference from the experience-oriented. It's just an expansion of that idea. Here, the evidence is intersubjective. It's like the client and therapist have to agree that this is the change that needs to be made, and no other evidence is really required. In this orientation, cultural psychology, sociology, anthropology, you see that music therapy is a humanity. So far we've had music therapy as a science, music therapy as an art, music therapy as a humanity. All absolutely viable, all absolutely effective in their own arenas of practice. Okay, next slide. Here the therapist is not an expert. They're just more experienced. There are some models in the experience thinking that also believe that, but here it's really, it's almost a requirement that you not take a hierarchical position with the client. Hierarchical meaning any kind of superiority. Okay, next slide. So if we compare, we say, well, all right, each way of thinking responds to a different need. That's important because it implies that one can't meet the need necessarily of another. Otherwise, it wouldn't have been developed in the first place. And it wouldn't be practiced in the first place. So the good thing is that each way uses the same musical and non-musical resources in different ways. So the outcome thinker, for instance, uses music much more in terms of its properties to induce a specific response. Whereas the experienced thinker more uses music as a space, as a process, lets it wide open, tries to design a container around that process so that something's going to happen in that process that's relevant to the client. Each way gives therapist, client, and music different roles. We've already seen that. Each way relies upon different types of evidence. And because of this, it's impossible to determine which is better. They're all doing different things, and they're all expecting different kinds of evidence. So you can't use objective evidence to evaluate context thinking, and you can't use intersubjective evidence to prove therapeutic change in the outcome-oriented thinking. So it's like that game that we play as kids, rock, scissors, paper. Yeah, one thing does one thing, but is still going to be trumped by something else. That means that one way cannot replace the other. So that if I'm going to predict where music therapy has to go, it has to go to the next slide. Can we better serve our clients by moving away from one-way thinking to more integral thinking? Can we think about ourselves not having specific roles that we have to maintain every single moment of every single session with every single client and every single population? Can we think of ourselves as not always having to be the expert? Can we think of ourselves as not always being the co-participant? Can we think of ourselves as not being just objective in the kinds of evidence that we want, and think that sometimes we also need subjective evidence or intersubjective evidence? To do that, we've got to give up the role configurations that I was even going to present to you today. I don't want to present them anymore because, in a sense, those are things that we do. But as soon as you entrench and rigidify those roles, you're really taking away your ability to give full access to the client of the benefits of music therapy. So where does that lead us? Well, okay, let's take a simple method like song discussion and say, well, all right, what will we do with song discussion? Well, if you're working, I don't know, with substance abuse or something, you can say, well, sometimes I want to present a song, and I want that song to really bring a very specific message to those clients. I'm working for that lyrics and for the music to induce a certain feeling to go with that message. So that I'm really, in a sense, trying to change the way they think and the way they behave. And I know exactly where I want them to go. Great. That's one way of thinking. And it works. Okay. The second way of thinking is, can I just simply present them a song and let them find in the song their own experience? Can they identify what they see as the conflict in the song? Can they identify the feelings and the conflicts that they feel in the song? And in working in a group situation, what do we do with all these possibilities? What do we do with all these possible feelings and reactions and possible ways of thinking about substance abuse and how one can overcome it? And in the context-oriented, you're using a song, and you're using songs which are going to be cultural resources, which are going to reinforce either an understanding of how the culture supports substance abuse, and that you can recognize that you're living in an environment with music that actually supports substance abuse, and that you've got to be able to find a way of changing that, or changing your reaction to it. So if we think about songs, and we think about different ways of using songs. We've got to be open. Okay, next slide. So let's use different ways of thinking when working with clients who have different therapeutic needs. We want to focus on outcome when the change is really predictable and clearly recognized as a priority need. We know that this has to be done. It's the example always of like, the little kid is writing on the wallpaper. I don't care why he's writing on the wallpaper. I don't care whether he misses his mommy. Stop writing on the wallpaper. It's that simple. But sometimes that's not the case. So when I focus on outcome, I also have to see that contextual change may not be relevant, and it may be relevant. When I focus on experience, let's say, the change is not entirely predictable. And the therapeutic alternatives, let's see, I can't remember, this is the one that I changed this morning. What does that say? I have the wrong slide here. Read the slide. The slide is right. What I have here is not what I wanted to say. So the ultimate outcome of this slide is, here's what I want to say. You have to think the way your client needs you to think. You can't think the way you prefer to think. It's not up to you. Okay, let's go to the next slide. Integral thinking around timing. I realized when I prepared this presentation that one of the things that we really have not looked into carefully enough are the timing and the length of the responses or changes that we want from the client. And I think it makes a big difference because sometimes you're working and you need an immediate response and you know exactly what the client needs to do for them to be even able to engage in whatever is the therapeutic process that's going on. They just are not going to be able to do it until they exhibit that response. So that response is, in a sense, a prerequisite or en route objective to what you need to do. And so, in a sense, you do whatever needs to be done to get that response. Then there's another kind of change that we look for, and the best example I can think of is that you're working with a burn patient and you're trying to manage pain during the debridement process, and you think, well, okay, this isn't a long-term pain management process. This is like, I'm going to be working with this client during the debridement so that what I'm working for, in a sense, relatively short-term responses over a short period of time, because this person's not going to be debrided forever. Of course, I could think, well, maybe he does or she does need to have pain management, but right now that's not the priority. Right now the priority is they've got to get through debridement and I'm going to help them to manage their pain. So that's a short term. And then there's the long term. And the long term is, what are they going to take away from it? And we've got to think about these things much more than we have, because I think that this timing situation helps us to really look at when we should be outcome-oriented, when we should be experience-oriented, and when we should be contextual-oriented. And then when you think about it, well, okay, if I'm experience-oriented, I'm thinking about a GIM client that I worked with, and she was an excellent candidate. She had been abused, and she was terrified of the music. I think, well, gee, how are we going to do GIM with somebody who's terrified of the music? And so I came up with an idea. I had to somehow reduce her anxiety about the music. That's what I wanted to do. And it was one of those prerequisites. We're not going to be able to do this until we can find some way of managing this. But I didn't know how to manage it, because every time I would guide her, I couldn't just simply say, oh, the music's okay, it's safe, don't worry about it. because she was scared of it. So I had nothing that I could do in terms of intervention during the music that was going to work. So I decided, well, you know what, I'm just going to give you the music. Next week, I'm going to use this music. Listen to it. If there's anything scary in it, let me know. Next time she came in, she didn't have trouble. She said, well, there are a few rough spots. She said, I'm not crazy about the woman's voice. But she said, you know, I think I can do it. So, okay, we go into the session. I can see she's starting to get anxious when the woman's voice comes in. Okay, I'm engaging her in experience to deal with abuse, and she's really focusing on the music being the abuser. So I'm putting her, in a sense, in an experience, and this is the whole point. I'm putting her in an experience where she can really address that issue on some metaphoric or analogical way. So now her whole struggle with the music becomes very significant because it really, in a sense, is the opening to how she's going to deal with the abuser. And by the way, she's living with an abuser. So she starts getting anxious during the session when the voice comes on. Well, I know that I want to help her in that, but I don't want to give her any kind of a solution, so I just try to address her anxiety, and I say, take a deep breath. That taking of a deep breath gives her some time to relax and to reduce that anxiety just enough so that she can really begin to find different ways of coping with it. So here's what I'm doing. I'm being very outcome oriented. I want her not to be so anxious that she can't deal with this issue and find a solution to it. So I'm really trying to elicit a very specific response. I'm being just as bossy as anybody else. And we can say in GIM that we're so holy and non-directive. The fact is, sometimes we go after very specific responses, and that it's absolutely essential for that approach to work. Sorry. So here we are thinking already in an experience-oriented, and we're thinking in an outcome-oriented. And now I'm thinking, and now when she goes home, what in the world is she going to do with this guy she's living with? And is it my business to change him? Or how do I work with her so that she's going to do something with him? But I don't want to say, leave this guy. I don't want to say, you got to just, tell him hands off. I don't know what the answer is, but I know that somehow part of her therapy is going to involve her addressing the context in which she is choosing to live right now. And from a feminist point of view, I'm thinking, and what do you need to do? What do you need to do to identify with other women who have empowered themselves after abuse? How can I give you the resources of those other women? How can we turn this process into something where you become a social force? You become an advocate. So you can see then that timing, I can't deal with the abuser until I've dealt with the experience. Until I've got all the outcomes that are needed in order to engage her in the experience. I've got to think integrally. I have to. Okay, next slide. That means we can use music in many different ways. We can use verbalizations in many different ways. Like I said, in outcome-oriented, you use as a stimulus or a reinforcer. Well, you know what? When I got a GIM session, I use music as a stimulus, and a lot of times I use verbalizations as a reinforcer. And the purpose is to elicit a very specific response. Sometimes I want the GIM client to have a very specific musical response. Because, for instance, If they're in a music program and they're imaging to a music program and they don't really hear everything that's in the music, then I want to help them to perceive those aspects of the music which might be a resource for them. So I have to, in a sense, teach them about the music and say, can you focus on the lower notes? So we can use it as the change process, which is the experience-oriented. We can use it as a representative product, as an aesthetic experience, as a cultural resource. And we can use those, in other words, in relationship to those three goals. Okay, next slide. Integral thinking in terms of the use of the self. Well, we know in a medical model that your expertise has to be clear, and you have to have a certain professional distance that perhaps you wouldn't have if you were working in another model. On the other hand, some of the ways of being in the context-oriented model you probably could never use in a medical model. So that you've got to free yourself to be appropriate to the client, the population, in the setting that you're working in. If you're an outcome thinker and you think that the outcome thinker can work everywhere and use the same role and the same way of being with clients, you're going to find out that it's not going to work. So sometimes you can be an expert. Sometimes you can be a scientist. Sometimes your expertise is about the music. Sometimes your expertise is about life. Sometimes your expertise is about community. Sometimes your expertise is about the client. You can't just think that your expertise can only be one thing. Now I say it after all the competencies, you know. Now I'm really telling you the truth. I don't know about those competencies now, I tell you. I can say that now I'm retired. Sometimes you have to be a phenomenal musician. Phenomenal. Sometimes that lessens in importance. Sometimes you have to be a real empath, and sometimes you simply cannot. You just can't. Because if you do, you're going to get so overwhelmed that it's going to be impossible. So you have to maintain your distance. All I'm trying to say is don't get stuck. Sometimes you need to be an advocate. Sometimes you need to be a surrogate. These are all sometimes. These are all sometimes. Next slide. It changes. All this changes your ideas about directiveness too, because if you're honest, you have to be directive and you have to be non-directive. You can't be one or the other. So that sometimes you see you can be, you can set the goal. In outcome thinking, you set the goal. You know exactly what needs to be done. In experience, you need to co-determine the goal with the client because you're not quite sure. You got to lead and follow, and lead and follow, and lead and follow. And it's sort of like this constant process of negotiating and shaping what this experience is going to be all about. And then sometimes you just let the client set the goal altogether. Be open to that. I was thinking, in fact, as I was coming down the elevator, that we worry about what we do. And we think about what we should be doing. And I think we have to shift that to how can we give the client the most free will to do what they need to do? How can we give them as much control over what they need to do, even in determining what they need to do? And if you think that way, you can't come in with a rigid orientation. With some clients, they're not going to be able to set the goal. Some clients, they can only do it partially. And some clients are really very clear. Same thing with the music. I always had a difference of opinion about improvisational music therapy in that often I just didn't improvise with the client. I did not want to influence it. I didn't want to direct it. I didn't want to be a part of it. And I think you've got to give them control of the music just as much as you have control of the music. I remember, I was telling the story, I have worked with this gal who was in her 20s, and she was schizophrenic, and she loved to sing. And she would come in, she'd sit at the piano with me, I'd open the fake book, and we would go through, she would pick the songs that we would sing. She would sing them. And if the song was in the wrong key, she'd just change the key. I hated that when that happened, but I really did. I hate transposing. Anyway, but she began to evolve a certain way where she would pick certain kinds of songs in the beginning, and then in the middle, she would pick certain kinds of songs, and then she'd always end with either You Never Walk Alone, Climb Every Mountain, or Hello, Dolly. And she always cried in You'll Never Walk Alone, and she always cried in Climb Every Mountain, and she always got up and danced when she did Hello, Dolly. But she was finding, in a sense, she was doing it all. She was putting herself in the feelings that she needed to feel at that moment, and she was finding the way to resolve them. And I was just her accompanist. That's all. That's all. And for that, the funniest thing of all is that she gave me a name. And the name was Gigolo. J-I-G-E-L-O-W. And so when they would come down from their residences and come down into the building where the music was, you know, we'd be standing at the doors waiting for everybody, and she'd be passing us and going off to her classroom or something. And then she'd look out the side of her head like this, say, Gigolo, J-I-G-E-L-O-W. And of course, all the staff would look at me like, what is going on? So I let her direct the session. And the interesting thing about her is that she really would have psychotic breaks where she would go into really complete hallucinations. And then I took control. And as she had them, I brought out the paper and the pencil, and I tried to slow her down. I didn't want to use music then, because the music could just very well speed up everything and enhance everything. I wanted to slow it down, so I asked her to draw what she was seeing, and it finally pulled her back. But it's a good example of being able to not direct the music, to not direct the session, and sometimes to really just take over. Okay, next slide. I'm not going through everything because it's too much. Integral thinking means that you've got different forms of evidence, and that has become a really important issue that I think that we're dealing with now in our writings and in the association and so forth, that there have to be different kinds of evidence that we look at in music therapy in this world where, you know, the medical model can't dominate what we do. We can't work with a client and go after an outcome that's measurable because that's what the medical community wants us to do. We have to somehow meet the expectations, let's say, of whatever community we're working in, medical or psychodynamic or whatever, and at the same time really be able to address the needs of the client. But the client's needs are really still primary. So in terms of evidence, we've got all kinds of evidence that we're not really, in a sense, allowing into our thinking. Musical evidence is still musical evidence. It's more evidence to us, yes, but that still provides us with ways of hearing client change. And maybe that's only a type of evidence that we could use in these kinds of gatherings. But it's a type of evidence nevertheless, and you can't just say it's of no use. So you can have musical or non-musical evidence, you can have objective or subjective evidence. You can look at short-term effects or long-term effects. And that goes back again to the whole idea of clinical trials, for instance. I think we have to really start looking at, we can get outcomes, and they can have statistical significance, or they can have clinical significance because the effect size was large enough to think that it's clinically significant. But we still have to really deal with the issue of whether we can only promise that this is a short-term effect or a long-term effect. We can use evidence that's in the session and out of the session. We can use evidence that's coming from the client and evidence that's coming from the context. Okay, implications. Last slide. Clients. Integral thinking, maybe not the way I've outlined it. Maybe the way you can imagine it for yourself. Will provide the full range of benefits of music therapy for the client. This is the most compelling reason for you to expand your way of thinking. Always keep in mind that your main responsibility is to serve the client in the best way you can. That means that you cannot let your own biases or preferences or your own limited way of thinking or the limited way of thinking of your mentors to deprive your clients of the full access to music therapy. In some ways, I see this as advocacy. If you want to advocate for your client, look to yourself first and see what changes you have to make to truly advocate for your client. Thanks. Music therapists. Okay, first thing I want to say about the implications of this is that if you limit yourself to one way of thinking, you are ethically bound to limit your practice accordingly. You cannot promise the benefits of other ways of thinking. One way is a limited way of working with clients, and you must clearly identify the indications and contraindications of that way of thinking. And to not do so, and to claim that you can do more than that way of thinking allows you, is really unethical. You can't promise the client benefits of all three ways of thinking if you are only subscribing to one. No way. And if you do, you should have experience-oriented music therapy, which would show you that you're delusional. Not with me. The other problem is burnout. I mean, you know, we do still have a problem of burnout. We have a problem of what's it called when you lose members? Yeah, attrition. And I think that possibly part of it could be due to this. we're only able sometimes to get someone, when they come into undergraduate school, we can only get them into one way of thinking by the time they finish. And then when they go out into the world and they have that one way of thinking, and it doesn't work, they get really discouraged. Because in some ways they're assuming that that's the way they should be doing it. And so therefore the only thing that they can conclude is that I'm not doing it very well. Well, they might be doing it perfectly, it's just that they're doing it in the wrong place with the wrong people. So I think that burnout and attrition is one possible implication of one-way thinking. And okay, so one-way thinking. And by that I mean really in any one of those ways of thinking. Okay, leadership. Leadership is about advocating for different ways of thinking. A leader is someone who can find alternatives. A leader is someone who can see that something isn't working and can try to find a way of identifying something that will work. And the only way they can do that is that they got to think in different ways until the alternative comes to them. So in so many ways, I would say leadership is integral thinking. You can't be a good leader without integral thinking because you have to address all the ways of thinking that are within your constituency. The other thing is that when leadership doesn't do this, the problem is, and this is human nature, one-way thinkers sometimes begin to believe that they are the only ones that are right. So the one-way thinkers in the outcome camp disparage the one-way thinkers in the experience camp, who disparage and fight with the one-way thinkers in the context camp. So to our clients and to our healthcare colleagues, we become a fragmented profession of one-way thinkers. And this obviously calls into question the usefulness and potential benefits of all three ways of thinking. All three ways of thinking lose. Education and training. Well, I think it's timely because I've taught for a long time and I've tried to assess many years, what is it that I ended up really doing? What did they know when they got out? What were they able to do when they got out? It's a really difficult question to answer. But one thing I'm sure of, and I can see this in a lot of other, in a lot of other training programs and educational programs, is that there are those educators who opt for training somebody in one way of thinking because they see it as the only possible way of making that person competent to go out into the field and be efficient. But the problem is that, like I said before, they go out in the field and that one way of thinking is not enough. And that's in any of them. So, if you go to a school where there's experience-oriented thinking, guess what? You're going to go out and you're going to try and work in pediatrics and you're not going to know what the hell to do. So that raises the question, can we really teach and train people to be integral thinkers within an undergraduate degree? It's hard. I don't know how to do it. I've been teaching for 40 years. I haven't come up with a way. So, whatever support that you can give to raising the amount of education and training that future music therapists get, I think will help us all in the long run. I'm not done yet. That person's from Temple, I can tell. No, in closing, I guess I've really said everything I wanted to say, that we really owe our clients their free will to the extent that they can exercise it. We owe our clients the flexibility to think differently when that's so required.